One of the concerns that consistently comes up in my work with both my clients and with oncology providers is the tension of navigating fertility preservation when someone is facing a cancer diagnosis. These conversations are often happening at the same time treatment decisions are being made, and it can feel like everything is all on the line all at once. I'm Tiffany Sharifi, a licensed counselor and certified sex therapist specializing in oncology related sexual health. And today I am joined by Dr. Johnston, a reproductive endocrinologist at Shady Grove Fertility who specializes in oncofertility. I've known Dr. Johnston since 2019, and over the years, I've consistently experienced her as incredibly knowledgeable, thoughtful, and she also just brings both a deep scientific expertise and a compassion to conversations that are often overwhelming for her patients. In this conversation, we'll talk about timelines, what fertility preservation actually looks like, collaboration between oncology and fertility teams, and how providers can feel more equipped when these questions arise. While much of this discussion is geared towards oncology providers who want to feel more equipped when fertility concerns arise, individuals navigating cancer treatment themselves may also find this discussion helpful. So, without further ado, here is my conversation with Dr. Johnston. Hi, Dr. Johnston. Thank you so much for being here today. And I want to just open up with, you sharing a little bit about yourself and your work and how you got into oncofertility.
Yeah. No, thanks for having me. I'm really excited to talk a little bit more about this topic today. So I opened Shady Grove Fertility in Richmond, Virginia in 2018, and I was very proud to be the first female full-time reproductive endocrinologist in our community, and really serve the families and patients who are in need of fertility services, from those that were starting to try and conceive, those that were interested more about learning about their future fertility, those that unfortunately had suffered miscarriage or had physiologic issues that unfortunately were causing some challenges. But a large slice of the patients that I serve, which we're going to be talking about today, are those patients who are in the whirlwind of a new diagnosis, unfortunately, of malignancy. And so, partnering with the local oncologists, I've been able to help those patients understand more about their options for fertility preservation and for future childbearing. Credential wise, it takes a minute to get to this point, very proudly. So, I've had a lot of great mentors. So, I'm originally a New Yorker, transplanted to Virginia before opening the practice here. I was actually faculty at Wake Forest. I was the medical chief there, and served patients in the same capacity, many of whom were my professional colleagues, many of whom delayed childbearing to advance their careers. And really proud to say now 8 years in the Richmond community, serving the patients of the greater Richmond community. And since then, we've actually expanded out to the Roanoke area, down to Hampton Roads area. So I'm board certified both as an OBGYN, and then we do an additional 3 years of training called fellowship, where we really focus on reproductive endocrinology and infertility issues. Trained as a robotic surgeon, minimally invasive surgeon. Now my practice focus is mainly on advanced reproductive technologies.
Nice. Thank you for sharing that.
Yeah.
So, you can continue to listen. You're in good hands here today as we talk through
Mhm.
this. I'll start with just remembering some of the clients that I've served and doing sex therapy with them once they were diagnosed with cancer or even after
Yeah.
they had finished treatment. Most of my clients were women, mostly breast cancer
Yes.
survivors or people going through breast cancer treatment. I work with some men
Sure.
as well, but and unfortunately, a lot of my clients were quite young,
Mm.
and so there was a lot of stress and tension around fertility, and so for some people, even if they were partnered in a serious relationship, they couldn't even
Mhm.
engage that conversation about it.
Mhm.
It was just too much or
Mm.
too overwhelming. And then for
Agree.
some people, they could talk about the grief of
Mm.
infertility and the grief
Mhm.
of how, things aren't going to be like they anticipated. And so
Yeah.
I think for most people, or I guess in both cases, I found a reluctancy to even engage the conversation of seeing
Mm,
a reproductive endocrinologist. And I don't know how much guidance they got from their oncology team at the hospital, but for them, I could tell there was a bit of a wall. And I think that was due to lack of information from what I could
yeah.
gather. And so, what can providers know, from your perspective as a reproductive endocrinologist, what do they need to understand about the timeline of for fertility preservation? What does that look like? What does a cycle look like? Because I know there's issues sometimes about delaying treatment,
Mhm.
and how that will impact the patient. But just share a little bit about the timeline.
Yeah, I mean, there's so much to unpack there. So I think it's great that we're talking about it. So, the first thing that you brought up, I think, is really pertinent, which is just that a lot of patients unfortunately feel like they weren't even given this information to consider. And so sadly, I've met those patients, right? Now they've thankfully survived their diagnosis of malignancy.
Mhm.
They're in remission. Wonderful. Yay. We cheer those folks on. But they come to me, and you're right, the burden of the grief is heavy, in the sense that not only are they grieving the loss of their um time, right? And so that unfortunately can cause some changes for fertility, which we'll talk about. But they feel like they were never coached to even ask the question, or never given the opportunity to ask the question. So I think first and foremost, something that's really important to me is empowering that patient who literally just met with their oncologist. Maybe the door just closed and they literally walked across the hall here where we are at Henrico Doctors Hospital. Um, wow, they're just in that whirlwind. And so the first thing that I say to them is, first and foremost, this is about information, right? There are several different options of things that we can do. But if this is overwhelming to you, there is nothing wrong with saying, this is just not for me, because that's an empowered choice as well, right? For many of my patients, they say, as much as I'd love to consider some of these options, I really just need to focus on survivability right now, and my chemotherapy regimen, or the surgery that's planned for me, or my neoadjuvant chemotherapy, whatever's on the docket for them. And that is 100% valid, but at least they've been given that choice and empowered to decline treatment. So number one, declining treatment is a-okay. So I try and encourage them to recognize that that's a valid choice. Okay.
Mhm.
But moreover, what is on the docket, right? So if someone presents to me, I'd say we stratify this into two ways. So there are some medications that can be given during chemotherapy to induce kind of a dormant state in the ovaries. The most common one is actually an injection. It's called Lupron. And where this has actually been studied, when it's looked at internationally, is looking at patients that are more likely to resume having their menstrual periods after they have any kind of treatment. And what we observe is that, it kind of makes sense. If a patient's younger, right, so prepubertal or peripubertal, that patient, that woman in this case that we're talking about female patients, is more likely to resume her menstrual periods, more likely to have eggs, even after she's been exposed to a toxic therapy like chemotherapy, which we know works on rapidly dividing cells, wonderful, works against cancer cells, but unfortunately also hits hard on the resting eggs, of which, as women, we only have a finite group, right? They're non-renewable resource, like our teeth, right? We got to be good stewards of them. So, so one option for some of our patients is actually to take that suppressive medication, inducing a dormant state so they're not rapidly dividing cells. And there's some evidence that that may actually preserve some of their fertility, but it's a gamble, right? We don't know, is that woman on the back end going to actually have resumption of her periods, or unfortunately was the chemotherapy so toxic, and there's scales looking at this depending on what agents they're going to need to use, how long the regimen's going to be. So it's not one size fits all, and we can help patients with that. But that's one option. The more conservative option, which is something that I offer very frequently to patients in the throes of oncofertility, are either preserving eggs, right, or preserving embryos. So we could definitely talk a little bit about that.
Yes, no, that was really helpful. And I think
Mm,
just understanding, and even, there's so many times when there's collaboration,
mhm.
and you're the main provider, the provider that may have given a
Hmm.
diagnosis like that, the patient often wants to know, well, what is this going to be like? Like if I
Oh yeah.
go and see this fertility specialist, what is this going to be like? And so
Hmm.
just having that information, I think, will help providers to guide their patients and maybe provide a level of comfort. Like, hey, you don't have to make any decisions. It's just
Hmm.
really helpful for you to go and get information. And then I hear
Hmm.
it's even better if they know their regimen. So if they
Hmm.
know what types of chemotherapy or immunotherapy they'll be having,
That's right.
that can help you guide the discussion with them as well.
Precisely right. And also, given that this is all new diagnosis, some of them have a few things on the horizon. They know when their oncologist wants to start treatment. Perhaps they want to have a port placement for access so that they're not having multiple intravenous sticks and it's a safer way to deliver the chemotherapy. So that's something we need to plan around. Some patients now are actually having chemotherapy prior to removal of the cancer. So that's called neoadjuvant chemotherapy. Others are having removal of the mass and then chemotherapy after. So it's really just dependent on their diagnosis. But to that end, really what we're trying to do is collect eggs before chemotherapy is administered, because that's kind of that most precious resource that has not been impacted by those chemical agents. And probably one of the most challenging pieces too for my patients to understand, and I wish we had a better lens for this, but is to understand, um, how do we tell if an egg is good quality or not? Because I meet women of all different ages, right? And just at baseline, outside of the lens of chemotherapy or oncofertility or oncologic treatment for us as women, our age really determines the quality of our eggs because the eggs have been stored in our bodies since we were fetuses. So when I meet a woman who's in her 20s, even though she may have a new diagnosis of malignancy, the eggs that we would harvest from her are going to be better quality than a woman in her 30s or than a woman in her 40s. All of them may be good candidates, but it's just good counseling to know what do we expect the outcome of these eggs to be if we chose to use them down the line. And so oftentimes when I'm meeting with these women, they also have no idea what their quantity of eggs are. And so that's an important thing that we can catch up with in the moment. More traditionally, when I'm seeing fertility patients, we'll actually do a blood hormone level that's called an AMH. So that stands for anti-Müllerian hormone. And that can be drawn anytime in the cycle. But in these more rapid cases, because it can take several days to come back, I usually try and assess their quantity by actually looking at the ovaries. So we look for a characteristic within the ovaries. And if you're a carb lover, we're often reminded of a chocolate chip cookie, or if you're an oatmeal raisin person, that's fine too. And our ovaries, they're somewhat oval shaped, so they kind of reference, a sweet, and the little dark stippling within the ovaries, those are called antral follicles. So I can meet a patient for a consultation today and have her come in the office this afternoon or tomorrow to have an intravaginal ultrasound where we can really get good imaging of the ovaries to have a sense of quantity of eggs. And that's really helpful in knowing what we would expect to be able to stimulate during a treatment cycle. We can certainly talk about what that would entail.
Yes, that is one of my next questions, and it seems like overall the best advice would be to try to retrieve those eggs
Mm,
before treatments like chemotherapy begin.
that's right.
I do find with my male clients,
Hmm.
since fertility treatments are less invasive, and I want you to talk about it,
Hmm.
in more depth, especially what the woman client has to go through.
Hmm.
My male clients, it's very straightforward. Like it's barely
Hmm.
even a blip for them to talk about.
Hmm.
Sometimes they're kind of like, oh yeah, I had to do this thing and we want kids or we want more kids or I want kids in the future. So yep, you went and gave my sample and now I'm going to start treatment. And
That's
it's
right.
not there, it doesn't seem as emotionally heavy
Hmm.
as, and again, this is anecdotal. I didn't look at
Yeah.
the extensive research, but just knowing how invasive it is for women,
Hmm.
I think that's a big barricade. And I think, again, not
For
knowing what
sure.
the cycle is like. So, what is
Yeah.
that cycle and egg retrieval process like?
Hmm. Yeah, it's great to talk about, and for sure, and I don't mean to not focus on the male patients because they're so important too. And I hope that everyone has a chance to be counseled who are in these difficult situations. But you're right, because it's their testicles are always producing sperm. If they're able to ejaculate, and for some it's difficult. They're not feeling well. They're ill. They're in a new diagnosis of malignancy. They're stressed. Right. There's certainly psychological factors around sexual function, as you well know. Some of them are unable to produce a sperm specimen, and certainly we also have surgical options in those cases for the men where we can actually take a small piece of testicular tissue from them where there is sperm that can be stored and frozen. And both those, either ejaculated semen or testicular derived tissue, they can be frozen. Medically, we call it vitrification. So it's a deep liquid nitrogen freeze where those samples can be stored indefinitely, such that they don't degrade over time, kind of like our home freezers, right? So I think your observation is right on. So the female patients that are now in the throes of a new diagnosis of malignancy, not only do they need to think about the finite resources that they have, but how to preserve them. So you're exactly right on track that we want to take those oocytes before they're exposed to chemotherapy. And I think probably a misconception is that the eggs can just be harvested on any day. And unfortunately, that's not the case. So the piece that we help with is the process of not only stimulating the ovaries, but actually getting to the goal, which is not just an egg, but rather a mature egg. And that's the important thing that we're getting to try and harvest for our patients for use. And to get from a small egg to a mature egg, for most women, it takes about 10 days of self administering an under the skin shot, a subcutaneous injection. And typically, it'll be 2 or 3 injections that they're taking. A lot of my patients are pretty overwhelmed by that thought. They've never given themselves an injection. So we have a lot of support through our nursing teams, home injection visiting services, video modules, really to get patients to the point where they feel like they can self-administer these medications. I've never met a patient that doesn't give it pause, right? To say, okay, I'm not sure I can do this. But that 10 days is necessary because we really have to grow. Medically, we'll call it a cohort, so a whole grouping of eggs that we're growing at the same time with the purpose of maximizing yield. Now, it's important to mention that each and every month as women, when we're just having a regular menstrual cycle, we actually have a really nice grouping of eggs that kind of presents itself and says, here, pick me, pick me. And really, for most women, only one of those eggs in a natural cycle is ovulated, but many more of them actually die that same month. They're not saved month to month. Now, for most women, then another cohort will appear in the subsequent month. But the point here in highlighting this physiology is that patients are often worried that if they harvest eggs now, if they freeze eggs before exposure to chemotherapy, in some way, perhaps they're actually diminishing their future capacity to return to having eggs. And that's not the case at all. More accurately, by taking medications for those 10 days, and what we're actually taking is liquid form of the same hormones that our brain normally makes, so FSH and LH, to stimulate the ovaries to grow multiple eggs. We're really rescuing those that would have not been available the subsequent month so that we can freeze them in real time. Now, if that patient has a male partner, or if they choose to expose them to a sperm source, which can be donor sperm, both of those are options once the eggs are harvested. So they can either be frozen separately, medically vitrified, or they can be exposed to sperm once they're removed from the body.
Okay. Yeah, so
Mhm.
it sounds like overall about
Mhm.
10 to or so days of
Mhm. That's
injection
right.
stimulation of the
Yes.
ovaries, and then there's a
Yeah.
procedure to
Mhm.
retrieve the eggs and
Yeah.
bring as many as you can to maturity.
That's right. But we definitely should talk about it because I think that, I like to get in the weeds a little bit because I do still think, and you're right to go into details because it's nerve-wracking for patients who are considering these things, right? So I often try to mirror for my patients, how are they going to feel? So the good news is that for the first 5 days that most women are doing self injections, of course they're stressed, of course they're nervous, of course they're scared. But from a hormonal standpoint, the good news is that slowly their estrogen is rising. And in states for us as women, when our estrogen level is rising, we actually feel pretty good. We don't feel excessively fatigued. We don't feel enhancement of anxiety or depressive symptoms. Those things can occur for sure in very low estrogen states, like before a woman gets her menstrual period or in that perimenopausal time. But the good news is those first 5 days with the estrogen climbing, people feel pretty good. Now, full disclosure, the latter 5 days of that 10-day period of shots, people still feel good emotionally and in terms of fatigue, but definitely they feel bloated. So I always try and warn my patients, strategic dressing, right? Pick something that's kind of your stretchy pants, not your favorite pair of jeans, A-line dresses, something that's, comfortable. And it's not to say a colleague or a family member is going to notice it. They're not going to look different externally, but they're going to have a sense of heaviness, of weightedness in the pelvis. My patients often describe it to me kind of as constipation type symptoms. Again, not pain, but just fullness, kind of, I'm just feeling bloated. Unfortunately, that's pretty common. Now, it's purposeful, right? Because they're feeling that bloating because the ovaries are enlarging in response to the daily injection. So rather than making just one egg bearing follicle, we're hopeful, depending on their age and egg count that we've assessed ahead of time, that they're making as many as we can possibly harvest, right? So on average for our patients, they're making 10 or 12 eggs, right? In patients that even have a more robust egg count, it may even be higher than that. And again, not depleting their future egg count, but we're trying to harvest those eggs before they actually undergo chemotherapy. Your point about how do we get them out, that's important to talk about. So it is a sedated procedure. Now, I clarify that it's not, full general anesthesia. So thankfully, patients don't have to have a breathing tube. They're not intubated. They're typically just given light sedation, so they're breathing on their own, and we just support them with either nasal prongs or a face mask. But it's pretty quick. So I was just doing this past weekend. I was on call for our practice. So, it takes us maybe 10, 12 minutes to actually retrieve the eggs. But the access point that I think surprises people is that we actually place an ultrasound vaginally, and we actually put a needle through the vaginal wall internally. So there's no incisions up on the patient's abdomen. And that's really exciting for my patients because it's much less to recover from. So typically that day, they're crampy, they're tired. We don't want them to drive or work that day. But the next day, they're feeling a little bit more themselves and kind of back to baseline. And if they're going to be proceeding into chemotherapy, they could start the next day.
Okay. No, I think thank you for providing that information and context. That's really important for people to understand because I think there's a misconception that
Hmm.
something like a cycle of IVF takes months and months. And I
Hmm.
don't know where that came from.
Hmm.
Really, it's a few weeks or at most, so a couple week
Yeah.
process for the most.
Yeah. And it's gotten a lot better. So there was a time that we really didn't understand how to start patients unless they were at the beginning of their menstrual cycle. And that's that in fertility cycles, more commonly, that's where we'll start patients when they're actually having their menstrual flow. But as you pointed out, sometimes we don't have that time to wait. And the oncologists are saying to us, we really need to boogie. We want to start this chemotherapy sooner rather than later. And of course it's, anxiety producing for the patient as well. And so, she wants to be able to move ahead and not defer her treatment. So the good news now is that our protocols for stimulating the ovaries have actually evolved to also be inclusive of different times in the menstrual cycle. So if the patient's 7 or 8 days into her period but hasn't yet ovulated, we can start medication stimulation. If she's already ovulated and waiting on a period, we can start medication stimulation. So there's more options now. We understand a little bit more about how to harvest eggs at those different time points in a menstrual cycle. So it's even more compressed than it used to be.
Okay, nice.
Mm-hmm.
So, and I think this may be helpful for some people that want to go forward with this, especially If they're like, okay, I know I have a partner, I know we want embryos, or I know I want to have children in the future, if they're
That's right.
sure. And then there's the other side where people, some people are just really overwhelmed and
Yeah.
they want to wait. So they want to know the risk of treatment. So what are my risks? What are my
Mm-hmm.
chances? And I know that's a really tough question to answer because it depends on many,
Hmm.
many factors. But what are those risks that you've seen in research of things, treatments such as chemotherapy or immunotherapy, radiation, things like that?
Yeah. Yeah, so the hardest part is, I ask my patients sometimes, it's like the patient that says, "Well, I always buy car insurance because I'm just never sure what's going to happen," and the person says, "Well, I only get, collision insurance because I just
Mhm.
want the lowest rate." Right? We all know, from our friend network, people that are more risk averse and people that are more risk takers. So definitely the patient that's more risk averse is going to elect to be more proactive in actually withdrawing eggs and either vitrifying or freezing eggs or making embryos. The good news is that with stimulation, to answer your question, the risks are very low. So, specifically, if patients know that they have an estrogen sensitive cancer, we have medications that can be given during the cycle to keep the estrogen levels low, such that stimulation, to our knowledge at this point, has never been shown to be associated with growth of the cancer during that short 10-day period. So that's great news. And then, on the back end, when they eventually want to use these eggs or embryos, and I just had a patient that graduated last week who herself, I'm proud to say, froze two embryos before doing treatment for her new diagnosis of breast cancer, and is now pregnant with one of those embryos ongoing in after having been in remission. But the timeline was tight, right? So her oncologist said, "Yes, you're in remission long enough that you do have a window where I'd be comfortable supporting pregnancy and you carrying that pregnancy. But if it doesn't occur in a certain time window, the oncologist felt very strongly that she needed to get back on suppressive therapy for her breast cancer." So there are tight windows that we partner with the oncologist on the back end if the patient's electing to carry pregnancy. Now we have to brace for the fact that green light may never come from the oncologist. The oncologist might say, "I'm sorry, I just don't think that the risk is merited based on the patient's pathology, based on the patient's scans, etc." And so, certainly within our practice, we also offer the patient opportunity to use a gestational carrier, whether that's someone that's known to them or someone through an agency match. That's been an avenue that many of my patients have elected to take. Some nuances there. Just back to the harvesting of eggs, depending on my patient's relationship status or interest in using donor sperm, that's one decision tree that we make together. But the other piece is that for some of my patients, they're actually waiting on results of their genetic screening to know if they carry a genetic condition that would be transmitted in the eggs. The most common one that we talk about is BRCA carriers. And so many of my patients will ask, "Well, if I were to harvest eggs, but then later find out that I am a carrier for this, can we test these eggs or fertilized embryos?" And the good news is that is feasible. The testing that we do within our laboratory is called pre-implantation genetic testing for monogenic diseases. It just rolls off the tongue. PGTM is what we call it. So if they do have a single gene disorder that's linked to their causation for their breast cancer, it is something that we have capacity to test for. So that's something that often comes up. Can we test now or can we test later?
Mhm.
Typically, the time frame is too tight that we can't test now, but we can test later.
Well, I'm sure that will be comforting for people to
Hmm.
understand as well, because I think
Yes.
that is a big part of fertility considerations, or the
Hmm.
like your desire to want to have children, especially when you're
Right.
faced with that diagnosis. So I'm
That's
glad
true.
you mentioned that, and you shared a little bit about collaboration, and that was my next
Hmm.
question. what do you find are best practices for collaboration between fertility specialists and
Mm,
oncology providers? Because we do know that that is the best for the patient, that shared decision
mhm.
making between the three when it comes to, their fertility or their future, plans for that. So what would you say is
Mm.
best practices, or how do you tend to collaborate with oncologists?
Yeah. The truth is, I feel very strongly about being a good steward of expediting the visits for these patients.
Mhm.
I just put myself in their shoes, right? No one wants to ever be in the shoes of someone that's grappling with a new diagnosis of cancer. So, what I don't want for them is having to call my call center and waiting and, being deferred. Obviously, there's some things we have to do, help to get their insurance information, understand if there's a copay for a visit, et cetera. But the truth of the matter is, for our local oncologists, they all have my cell phone number. And so commonly what happens is I'll get a text message to myself and one of my colleagues. Hey, I have someone that wants to come talk to you. Here's her, how can we best route her to you? And literally I'll be seeing her the next day.
Oh,
We still have capacity for doing video consults. So I'm always happy to meet with patients in person. That's where I am right now at our Henrico office. But I also feel like there's a lot of appointments on these patients' schedules. The one that I saw 2 weeks ago was planning around her bone scan. So
mhm.
obviously that was important for her not to defer. So I meet with a lot of patients on video. It's also pretty overwhelming to do this alone. So I also encourage patients, if they're electing to meet with me on video, to include a trusted friend or family member to be on the call as well, so that there can be another set of ears. And I find that really effective. And that person doesn't have to even be geographically in the same zip code. So I just want to make it as easy as possible for the patient really to be able to ask questions and have someone else there to support them.
No, I mean, I'm glad you mentioned that because when I'm um, initially doing like my initial
Hmm.
assessment with my clients, I often ask them who was with you when you found out
Mm,
late, or who goes with you to these appointments, because
yes.
just knowing that they have that support, if it's available, can go a long way
Hmm.
for just how they emotionally handle treatment. And
Agree.
so I'm glad you bring that up and encourage them to have a support person. Um, you know, Thinking about after treatment, if somebody
Mhm.
gets the information and they decide, I think I'm going to just wait until I'm cleared. Again, like I mentioned earlier, some of my clients are fairly young, and I know that's relative. So to a
Mhm.
teenager, I'm old, but to someone who is,
We're ancient to our
maybe 60s,
teenagers.
yeah, like, so I'm ancient
We're
to some,
ancient.
but young to some others. I'm in the middle, but what when I say young, I mean in their early 20s, and
Sure.
they just can't think about it at all, even if they
Yeah.
have the information. But a common question is, when is it safe to conceive after treatment? And it sounds like that may be a discussion between their oncologist and
Precisely.
even with your guidance as well. Is there anything
Yeah.
people should know, or especially providers should know, about the safety of conceiving after treatment? And when I say treatment, I mean something like chemotherapy or radiation,
Yeah.
not necessarily surgery, but chemo, radiation, immunotherapy.
Yeah, and there definitely are. It's so individualized, patient to patient, based on their diagnosis and all of their testing. Probably to build on that, the biggest question that I get asked from patients is, if my chemotherapy renders me into menopause, which
Mhm.
many do, right? Can I even use these embryos, right? That's where I really come in. And so the good news is, yeah, you can.
Nice.
So sadly, I meet many patients who unfortunately have gone through premature menopause, right? They're young women that shockingly, I just saw one this morning. Unfortunately, she carries a genetic condition where her egg count is very, very, very low. She's healthy, she's doing all the right things. It's just her genetics, unfortunately, have led her eggs to decline more rapidly. So, in the setting of chemotherapy, if a patient goes through menopause,
Mm.
she, with clearance from her oncologist, can take back estrogen and progesterone, which initially are taken either orally by mouth or in injectable form. And as long as she still has a uterus, her uterus can be responsive to those medications, even if she's not making eggs on her own because the chemotherapy has driven her into menopause. And that really shocks people sometimes. Um, the good news is patients feel pretty good on those medications, estrogen and progesterone. Um, Probably get some feedback that the progesterone is taken in injectable form. So that's deep intramuscular injections, which are uncomfortable but tolerable for patients. But then once the pregnancy transitions past 8 weeks, the placenta actually makes both those hormones itself. So again, not dependent on the ovaries making those hormones. Even if the patient's in menopause, the fetus actually supports itself during a pregnancy. After delivery, that patient can lactate, can breastfeed if they choose. Now they would get, a period after delivery and then unfortunately go back into their menopausal state. So they would, talk to their gynecologist or their oncologist about, what we need to do to protect bone health and heart health related to estrogens, what's safe given their receptor positivity and et cetera. But absolutely, even if the chemotherapy has driven them into menopause, many of them can still have a responsive uterus. Now, if it's not safe from their oncologist for them to take external estrogen and progesterone because of their malignancy, then that's where we would turn to a gestational carrier.
Okay.
Hmm.
Okay. So there is some hope on what
Hmm.
situation the person is, even if they, because I think there's an idea about menopause too, like that
Hmm.
shuts everything down, everything is over,
Hmm.
you can never
That's right.
carry a child, and that's just not true, just
Yeah, I think that's the big surprise to a lot of people, but pleasantly so, that they're excited that they've
right.
worked hard to harvest eggs, perhaps they've made embryos, and they're still able to take them back, even if the chemotherapy has caused them to go into menopause.
Okay. Yeah, and I know, just to be mindful of time, I wanted
Mhm.
to wrap up, but I have one more
Mhm.
question about what
Sure.
you would share, or what guidance would you give oncology providers to improve fertility related care?
Mm. Yeah, I think your focus on open communication and collaboration is key. Um, you know, um, the wonderful thing about advances in oncology treatment is that so many of our patients are surviving. Amen. Right? These horrible diagnoses. But of course, in the throes of their diagnosis, we have to think about their chemotherapy regimens and how to help them survive. But on the back end, we have to help them figure out what their life goals are because now they have a whole life ahead of them, albeit deferred for just a time while they're focused on eradication of their malignancy. So, my view is that fertility and family building is such an important goal there in talking and working with patients who are in this journey. They reflect to me that it's so important for them during their treatment to be able to fall into joy and to
Mhm.
know that there are gametes or oocytes waiting for them on the back end,
Mhm.
that they do have stored embryos, that if they're able to get through just one more day of treatment, there is something to move forward to. And I think there's psychologic benefit in that,
Mhm.
even if it's just theoretical, future family, because we don't know about those embryos taking as yet, but just the fact that they have those to be able to come back to use, that gives them an inner strength that helps bolster them in the darker days of their treatment. And so to be part of being able to help them to create those oocytes or embryos in storage is really an honor.
Mhm.
And I think the more we can have a facilitate an easy conversation, I think this is where telehealth is beautiful. So they don't have to drag into another appointment in another doctor's office, at
Mhm.
least give them information. I think then we've empowered those individuals to think about life after cancer, and life after, life within remission. Yeah.
Oh, Dr. Johnson, thank you so much. What a beautiful note to end on. I think everything you said kind of encompasses my passion around sexual
Mm.
health, and this is a big
Hmm.
part of it as well, because treatments are advancing, and that's so wonderful, and
Hmm.
that means that we need to have more care for people while they're going through treatment to preserve their dreams and their goals and their
Hmm.
vision for their life after treatment, because
Amen.
it doesn't just stop there for many because of the advancements in treatment. So thank you
Yeah.
so much
My
for
pleasure. It's great connecting with you today. Sure thing. And I'm happy to see any of these patients. We have two offices here in Richmond location, one at Stony Point and one on the Henrico Doctors Hospital campus. Um, if they're coffee drinkers, I'll meet them at the coffee pot. I'm a avid espresso drinker, but I really have enjoyed serving this community through Shady Grove Fertility. So thank you for having me here today.
Oh, and thank you for sharing that. I'll include all of the information below, so I should have said that initially.
No worries. That's
And
great.
where can they find you? What's the best place to reach out if they do want an appointment?
I know. Well, I do have a social media presence in Instagram, but appointment wise, I would love for them to access our Shady Grove Fertility website. It's wonderful. Also, with a lot of patient education resources. So, and certainly around oncofertility, we have a new patient access center that can route them to myself or some of my colleagues here in our Richmond, Hampton Roads, Roanoke community, so we can expedite their appointments. Mhm.
Okay. And then for a provider who wants to collaborate, how should they
Mhm.
contact you?
Yep, same.
Same
They
way?
can call us at New Patient Access Center and we'll access them and expedite their request. Mhm.
Okay, perfect. Thank you so much.
Thanks so much.
Thank you for listening to our conversation. I hope you could hear throughout our discussion the depth of thoughtfulness and care that Dr. Johnston brings to this work. If you're an oncology provider, my hope is that this helps you feel more equipped when fertility concerns and conversations arise, and more confident collaborating across disciplines to support the people you serve. If you're someone navigating cancer treatment yourself, or you're interested in learning more about Dr. Johnston and her work, her information is in the description below. And if you'd like to connect with me for further education, team trainings, or consultation around integrating sexual health and oncology care, you can find my information in the description as well, or just visit tiffanysharifi.com. I truly thank you for the work that you do and the care you bring to the people that you serve. Take care until next time.